I'm going to touch briefly on acute renal failure, also known as acute kidney injury. Um, and I really think that the videos that I've posted for you with our guest speaker can give you a much better picture of exactly what's happening in acute renal failure. But I want to talk a little bit first about what kind of people this might be. Um, Acute renal failure is kind of one of those diagnoses that's happily a lab diagnosis, as the criteria, which we'll talk about in a second here, tell us. It has to do with progressive, rapid reduction in kidney function and some key indicators in our lab values. But when would you suspect someone's perhaps in acute renal failure? What kind of patient would show up in your office that would make you say, I better get a comprehensive metabolic profile, which will give you all the information you need basically to get started with your creatinine and your and an ability to calculate their GFR. So, they don't walk in the door with a big sign on their forehead says, I'm in renal failure, you better check my creatinine. And they're not like our chronic renal failure patients who have a certain cast to their skin, who, kind of have a history of problems. And they may not be somebody like the diabetic who probably is heading towards chronic renal failure. They're going to be a wide variety of people. The cases I've seen kind of most frequently in practice are either post-infection or because of dehydration or blood loss. Now, in emergency or urgent care, you might see somebody who's really lost blood because of injury or illness, and they are going to, kind of be in that pre-renal thing. But you'll also see people who are simply dehydrated. I can remember a case of a fella who was a kind of hale and hearty 70-something-year-old elder, thin, fit, otherwise healthy, had gone out on his sailboat for the day. And sure, he drank plenty, but it was a warm day, the wind was up, and he lost a lot of fluids very quickly. And just because of his age, his already diminished GFR, just because of age, he quickly became sick. And he became sick in this way. He was extremely fatigued, and he had some GI upset as well. And we didn't really know what was going on, but when we took his labs, it was clear he was in renal failure. The other patient I remember distinctly was another not very elderly, but elderly gentleman, probably in his 60s or 70s, who came into urgent care a few days after he had been put on NSAIDs, ibuprofen, for a viral illness, just for aches and pains. He had taken the instructions quite literally, and every 4 to 6 hours he had taken 2 or 3 tablets of the over-the-counter preparation. That doesn't sound like a lot, but in a very short period of time, I think it was 5 days or so, he had gone into renal failure. Now, he probably had pre-existing borderline function, or maybe he was heading down the road. I don't remember whether he had any comorbidities, but I don't recall him as being a chronically ill kind of person. So those are two examples of something that happens fairly frequently. And one of my friends who worked in urgent care, who did it as a per diem gig, in addition to his full-time job in renal, he was a PA, and he said, I just don't let people have NSAIDs anymore. I'm so afraid of them. So it's very common. And of course, we have other people who, for a variety of reasons, as displayed on this slide, as well as in the videos, might go into acute renal failure. But they're going to look sick, but not catastrophically so. I mean, they're certainly not going to be in a life-threatening looking situation when you look at them. As the videos we'll talk about and we get most concerned about is high potassium. As you recall, potassium is an irritant to the cardiac muscle, and so we do not like high potassium, and that needs to be corrected post haste. So I'm going to turn you over to the video after this. But one more thought on this next slide is to just remind ourselves of the way that renal failure is classified. And so I'm going to take us out to this link here in a minute. So when we go to this link, it takes us to another one of my eMedicine Medscape articles. Again, great resource for you. And it reminds us that we can see that people can be heading towards renal failure if we're seeing very short-term situation of the increase in the serum creatinine by 1.5 times, or decrease in the GFR by 25%, and urine output less than 0.5 milliliters per kilogram per hour. Remember, normal is 1 milliliter per kg per hour for normal healthy adults. Again, when we see, many of you who've worked hospital say to yourself, boy, that's not really how it goes in the hospital, but a lot of your patients are probably in the risk or injury category just by virtue of their severe illness. Again, it goes down the line and kind of progressive to the point of failure. So we really have to see some pretty distinctive features of failure, such as an increase in the serum creatinine by 3 and or greater than 4 milligrams per deciliter, and then the urine output that way. So it's, again, it's considered very quick, very rapid changes in these parameters. So, you know, taking one creatinine in an office setting, unless it's very, very high, may not tell you whether the person is in the injury or risk category. Certainly would tell you if they're a failure, because you can compare it to predicted norms versus even just looking at their priors if you had them. If you don't have them, you'd still be looking at predicted norms and comparing them. Here on this slide, I'm introducing you to yet another great resource that I use quite a bit in terms of lab tests, and that is the labtestsonline.org website. I was going to, in class, have you seek this out, but I'm going to just make a few key points about blood values that we routinely measure in primary care to look at renal function. BUN, as most of us know, is not particularly specific. It does indicate an increase in the production of urea by protein metabolism. That's basically done through the liver. So it will elevate, of course, in the case of renal failure. However, it also elevates more commonly in dehydration, other syndromes like shock, stress, burns, MI, that's a myocardial infarction, that is, high protein diet, even certain medications, many medications can increase the BUN. So it's not particularly specific, but it is telling us that there is a problem, and we often see them reported together, BUN and creatinine, we really want to have a comfort where the values should be. Keep in mind that your folks who have probably some liver failure, early liver failure, a lot of our old alcoholics, their BUNs are quite low. And there are some other conditions too that can cause a low BUN, like malnutrition and so forth. So again, things are all relative. So a person may have a low BUN and you say, oh my gosh, their kidneys are in great shape. But that's not particularly helpful if they have concurring liver disease or liver stress. The creatinine, of course, is much more specific for renal failure and both acute and chronic, as we have said, and although there are some medications that will increase it. The other value that you see reported on lab tests is the GFR, and they do an estimated GFR, you know, on our lab tests. They don't have the patient's body mass to calculate specifically. GFR does shift a bit with body mass. However, it gives you kind of a ballpark figure. I would caution you that the GFR greater than 60 on a lab report only tells you that it's greater than 60. GFRs should be, for healthy people up in the kind of 90 range. It's kind of like grades. 90 is good, B is okay, B 80s and Bs are good, but okay. 70s, yeah, you're still fine. Don't worry about it too much. If you're older, it's probably expected. Over the 60 is what we really need. It's kind of the passing grade, if you will. But at that point, the person is kind of heading downhill. So one of the things we talk about in chronic renal disease, or looking at people who might be heading towards chronic renal disease, such as our diabetics, is we really kind of try to calculate exactly what their GFR is. So I'm going to take you out to the MedCalc for that, just to take a quick peek at it. So I changed my mind. I went over to the Kidney Foundation instead because their calculator is a little more simplistic. And I punched in some numbers here of a serum creatinine of 1.4, age of 75, a male who's not black, could be anything else. And their calculation comes up to 49 for a GFR. Much more accurate in terms of chronic renal disease, but it's certainly a quick check in terms of looking at things. So say we change his creatinine to 0.6, you can see that the value quickly changes to 98. So he's in the safe range. So that's the one I usually look at, the top number. So that would be pretty unusual probably for him to be that good at that age, but that's kind of how that's done. So here's the discussion board activity, the case that I said you'd probably see pretty often, a 23-year-old female college student with nausea, vomiting, and diarrhea for 24 hours. Each of you are going to be assigned to a group by alphabetical order of your last name, and to jump in and to work on the important questions for subjective, objective, making an assessment of your differential diagnoses, and working up a plan including rationale for your diagnostic testing, farm, non-farm, patient education, and follow-up. So in this case, when you get on the discussion board, my goal here is for folks to really dig in a bit and look for evidence-based resources that support your assertions. The activity will be worth points on the next exam. And in addition, you'll be asked to go out to the student presentations and pose a question to those students to provide some interaction there. Those are two very nice presentations ready for you. So at this point, I'll see you online. I hope you have a great winter vacation once this week is over. And please keep in touch as needed.